Management. And I invite Professor Anita Saxena from All India Institute, and she will talk on this very important subject.
Thank you, chairpersons, and thanks to Snehal and Prashant for organizing this meeting. It's a bit different topic, how to care for these patients beyond medical management. And when I asked Prashant what does he want me to speak on, because this is something that we don't even think in day-to-day practice, I realized there is a lot more than we can do, which actually we've not been doing it in a structured manner. So. Going forward. Okay, so just to introduce, I think with increasing longevity of these patients, the nature of their needs has evolved, and now we have to think about these new therapies not in just in terms of survival, but also in terms of quality of life over a long term. In fact, the newer therapies that we talk about must focus on the impact of the disease on day-to-day activities of the patient, and that is the job of the physician whosoever is treating these patients. And I think it is very, very important that parents of these children participate actively in the management of patients. And we saw one example yesterday when one of the parents talked about their child's story with pulmonary arterial hypertension, how much involvement is required for not just for dealing with the disease, but also with the emotional support, psychological support, and research in what all new treatments are available. So the important issues that I'm going to touch upon, some of which have already been talked about, is physical activity and rehabilitation, recommendations for travel, especially air travel. Pregnancy has been talked about in great length, but I'll maybe just show a little bit extra data about pregnancy as well as contraception, prevention of infections and the need for vaccinations, risk of anesthesia and non-cardiac surgeries and what is the data, then the psychological support and counseling that these parents and the patients require, empowerment of patients, and some of the other smaller issues which are also important. So coming to the physical activity, I think all of us grew up with the idea that physical activity is not a good thing for patients with pulmonary arterial hypertension because it can lead on to syncope and sudden cardiac death. And we've been telling some of our patients and their parents that they must not be taking activity participation in the school, which is not absolutely wrong. But I think some of the well-compensated patients who are in functional class 1 or 2 could perhaps be trained with exercise, which is definitely going to improve their 6-minute walk distance as well as their quality of life. And one such randomized control study was published in 2006, and since then there has been a number of publications. 2 more randomized control trials and a number of observational and control studies have been published. And as you can see, that majority of these studies are actually starting the exercise within hospital. So there is a 2 to 3 weeks in hospital period where there is a gradual increase in the exercise training program, and then of course these patients are sent home to go on for longer periods of exercise, which of course is supervised. And majority of these studies, I think barring a couple, have shown that there is improvement in the 6-minute walk distance, and many studies have actually shown that there is improvement in quality of life, there is improvement in functional class, peak oxygen uptake, peak exercise heart rate, and in fact 2 or 3 studies have shown that there is an actually fall in the peak systolic pulmonary artery pressure, at least at rest. So again, coming to the side effects of exercise, I think, as I said, we're all worried about it, but I think if done in a proper structured manner with gradually increasing exercise levels, then these training can really help, and very few minor complications have been described in majority of the studies. I think the largest study is with this 183 patients of pulmonary artery hypertension. Again, only 3 patients had something which was not really very grave. So what are the recommendations for exercise for these patients? It should be always personalized, individualized, and supervised, and it should be recommended for patients who are stable and well compensated. Start in a hospital setting, possibly for the first week or 2 with light aerobic exercises like walking and cycling, and I think we had one talk on this yesterday. And appropriate adjustment with daily activities is very important, because I think we need to know whether the child is going to school, how far the school is, how much exercise he has to do to go to the school, or what kind of walking the child is doing in the school. So we need to adjust with that. We should not just prescribe one set of exercise for every patient. Yoga exercises, I came across one study where they've said that these are not only helpful for exercise training, but they also perhaps improve breathing of these patients. So they tend to improve deep and slow breathing. And it is very, very important that we should not aggravate the symptoms, and we have to counsel these patients that if there is any increase in symptom, dizziness, pre-syncope, they need to stop and come back to the treating physician. And competitive sports in any way are contraindicated in patients with pulmonary artery hypertension. Now, the second thing is about, often asked question is about the travel. I think road and rail travel is safe, but hypoxia tends to occur in patients who are traveling by air. And of course, in Western countries where scuba diving is an exercise that is often talked about or is a hobby, I think, again, there could be hypoxia during sea diving. This was an interesting study which is published for adult patients, 34 adult patients with pulmonary artery hypertension, where the authors have actually measured pulse oximetry during commercial flights. And these are the patients who flew for less than 4 hours, and pulse oximeter or pulse saturation was assessed pre-boarding at peak level of height, while they were going to the washroom and walking at the peak level of height, and then at landing and, at the time when they're back to sea level. And this was, as you can see, that majority of these patients actually had a saturation which was reasonably good, 95% and above. But they tend to dip during the peak exercise despite these cabins being pressurized, and these, of course, commercial flights, and they return back to normal saturations at the time of landing. In fact, in their own study, about 25% of patients, or 1/4 of the patients, had systemic desaturation of less than 85%. And these are not the patients of Eisenmenger. So you presume that patients who already have a desaturation will perhaps desaturate little more on air travel. This is another study that has shown that about 11% of the patients with severe pulmonary artery hypertension experienced symptoms during flight in the form of dyspnea, peripheral edema, etc. So I think recommendations say that air travel can be undertaken, but one should avoid long duration flights, more than 8 hours. One should make sure that the person is well hydrated, take frequent leisure walks because we want to prevent DVT also, avoid alcohol during the flight, and supplemental oxygen may be required in patients who are in advanced class functional 3 or 4, or those who have a desaturation at sea level or arterial hypoxemia at sea level of PO2 of less than 60. So supplemental oxygen, just 2 to 4 liters per minute is what is required for these patients to take air travel. A full lecture has been taken on pregnancy, but I think just few points I wanted to highlight is that there is absolutely no contraindication to marriage, but it is important for the prospective family to know that the patient is suffering from pulmonary arterial hypertension, and therefore for women, pre-marriage counseling is very, very important. Pregnancy is not recommended. In fact, all the guidelines say that pregnancy is class 3, which means it is almost contraindicated. It has to be discouraged. And that is why it is very, very important to explain to the family about the risks of pregnancy in a woman with pulmonary arterial hypertension, and therefore what sort of contraception should be used is very, very important. But yes, we are all faced with women who are already pregnant when they present to us. Either they do not know about the diagnosis, or pulmonary artery hypertension is diagnosed for the first time during pregnancy, and then one has to deal with the way that yesterday we discussed about 2 cases, and has to be a very, very cautious multidisciplinary approach for these patients. And as discussed yesterday, endothelin receptor antagonists are contraindicated, and therefore one is really left, in India at least, with the therapy of with sildenafil. It has high mortality. This is a study which has shown that mortality has come down, but still it remains high at about 20%. And in Eisenmenger patient, the mortality may be even higher, 30 to 40%. The greatest period of risk is the peripartum period and the first week following delivery, and that is the time when majority of deaths have happened in these patients. Some risk factors for poor outcome of pregnancy include severe RV dysfunction, advanced functional class, low 6-minute walk distance, and elevated BNP and pro-anti-BNP, and these are the patients who need to be watched very, very carefully if they present during pregnancy. And as I said, that the recent guidelines of heart disease in pregnancy published in 2018 also mentioned that pregnancy is not recommended. There has been a little bit of debate about the mode of delivery, but I think majority of the people would prefer an elective, well-planned cesarean section. But yes, vaginal delivery with forceps resistance has been managed with many patients because vaginal delivery has much less blood loss compared to cesarean section. Whatever the method of delivery is, it is important to use epidural anesthesia with vasoconstrictor rather than general anesthesia. That's a preferred approach. As pregnancy is almost contraindicated or not recommended in patients with pulmonary artery hypertension, I think it is the duty of the physician to mention about the contraception methods. One can go for hormonal contraceptives, but barrier methods are definitely not to be used because they have a very high failure rate. It is always better to recommend permanent method of contraception for the women with pulmonary artery hypertension or for the partner. But if they do not want a permanent method, then one can think about something which is very effective but is non-permanent. Pulmonary infections are again more common in patients with pulmonary artery hypertension. Not only they are more common, they tend to be more associated with higher mortality and morbidity. And this was one study where it was shown that pneumonia could be responsible for 7% of deaths in patients with pulmonary artery hypertension. Therefore, any infection must be dealt with aggressively with antibiotics, antipyretics, and it is recommended that all these patients, and in case of children, their family members, should receive age-based recommended vaccines, especially including pneumococcal influenza vaccine, and in some countries even RSV vaccines are prescribed for these patients. And those who have right to left shunt, like Eisenmenger syndrome, must be given infective endocarditis prophylaxis as per the guidelines published earlier. The risk of anesthesia and non-cardiac surgery is definitely high. Even for elective surgeries, the mortality has been described to be 3 to 10%. So as high as 10% mortality has been described for elective surgeries. And of course, the risks are higher if there is emergency surgery, and risks are also higher in advanced patients who have functional class 2 or more, patients who have pre-capillary pulmonary hypertension. So those who have post-capillary are at a lesser risk than those who have pre-capillary pulmonary hypertension. Of course, RV dysfunction, elevated right atrial pressures, very high pulmonary artery pressures, low 6-minute walk distance, surgical time of more than 3 hours, and specifically high mortality has been described in orthopedic surgeries. I think because they last longer and there is a lot of chances of embolism and large and rapid blood loss. So patients, actually, there has been a lot of data on which anesthetic agent to use, but generally, there is really no specific anesthesia agent which is contraindicated or which is safer. But I think the overall consensus is that whatever anesthetics we use, it should be epidural anesthesia as far as possible and not general anesthesia. So a preoperative risk stratification, very, very important for these patients, including a full assessment by echo for right ventricular function, for tricuspid regurgitation, for various other parameters, and stabilize them as much as possible before going for surgery. But what is important intraoperatively, and I think that is what the anesthesiologist and the surgeons need to take care, and that is where our role comes, is to explain to them that any stimulus which increases PA pressure or pulmonary vascular resistance can push them into PA crisis. And therefore, hypoxia, hypercapnia, acidosis, all these things have to be avoided. So is systemic hypertension, very, very important. So they must remain well hydrated at the time of surgery, before surgery. They should not be fasting too long, and any amount of hypertension is to be avoided because we know that it can further lead on to RV dysfunction. Post-operatively, many of us tend to relax. Like in the postpartum period, I think we must realize that a lot of mortality and morbidity happens in the post-operative period. So even if they appear relatively stable, they need to be kept in the ICU with close monitoring for their blood pressure, for their fluid status, because any stimulus, including pain, including extubation, when we are weaning from ventilation, can actually push them into pulmonary artery crisis and even hypotension. And therefore, one needs to have a sort of a standby arrangement to deal with this crisis in the form of inhaled nitric oxide or iloprost if possible, and of course vasopressors have to be available because hypotension responds very well to the vasoconstrictor in these situations. I think much has been talked about the effect of pulmonary artery hypertension on the families as well as on the children. Fortunately, the prevalence of anxiety and depression is much higher in older patients and adults. Children have much less of these problems, but yes, their families tend to have anxiety and depression. So it is not just the patients, but their caregivers who also develop some of the psychiatric disorders. But the important point is that majority of them really do not need any drugs for anxiety or depression or panic disorders. Majority of them can actually be helped by proper counseling, relaxation training, cognitive behavior therapy, and they do reasonably well. This was one study I came across where they have actually surveyed the patients and their families with pulmonary artery hypertension, and of the 129 caregivers, 21% were actually caring for a child. And you can see that the effect of the disease is not just on the patient, but it is on the families as well. There is effect on employment, there is effect on inability to work, and overall household income. So I think this is a disease which is not just to the patient, but I think to the caregivers, to the families, very, very important. And that is true for many other diseases, but I think pulmonary hypertension being a chronic disease really takes a toll on the whole family. And therefore, psychological assistance counseling is very, very important. One has to spend time with the family of these patients, reassuring them. I think what is important is that the disease is not changed, but I think counseling helps them to develop coping skills and reach peace with the new state that they have been now put into once the diagnosis of PAH is made. Patient and parents empowerment, very important, because I think patients must participate and the parents must participate in the treatment of these patients. There are a lot of self-help groups, there are a lot of associations of pulmonary arterial hypertension, there are even pediatric self-help groups in the Western world. And I think the benefits are well shown in some of the literature studies as well, that because it decreases the sense of isolation, there is a lot of time to share success stories, and I think a lot of new things can be discussed. What are the precautions to be taken? What are the things to be avoided? What are the things they can do well so that that fear psychosis also goes away? But unfortunately, those self-help groups we do not have yet in India. But when I was Googling regarding pulmonary hypertension, I came across this website which answers a lot of questions. It is available to the lay public, and I think Prashant is also having some sort of an app where he has a lot of FAQs where the patients can go and find answers to these questions. But again, these are really empowering the patients, not really self-help groups. Iron deficiency anemia has been dealt with. I think we generally tend to underestimate its importance. It is common, even in Western world, and I'm sure it will be commoner in India because as it is anemia is more common. And besides the anemia part itself, I think low iron is associated with a worse outcome, as has been shown. It worsens symptoms, and iron supplementation should be given based on the hemoglobin as well as the serum iron levels. On the other hand, I think we are very sensitized to the issue of hyperviscosity in Eisenmenger syndrome, because we know that cyanotic adults tend to have high hemoglobin, and often we are recommending phlebotomy, but again we need to be careful because repeated phlebotomies can also lead on to iron deficiency, and we should restrict phlebotomy only for symptomatic patients who have symptoms of hyperviscosity, along with a very high hematocrit of maybe 70 or 65. Hydration, very, very important. I think many of us are catheterizing these patients. We should ensure that we do it first thing in the morning rather than make them wait for the entire day. And if we are delaying for some reason, we should replete their fluid status, because dehydration, again, is a very bad stimulus for pulmonary artery hypertensive crisis. Excessive heat is to be avoided. Sometimes these patients take hot baths. That can lead to vasodilation, and they may get syncope while in the bathroom taking bath. Care of the intravenous lines is, I think, our responsibility. Patients who have a right to left shunt, we need to be very careful when we are injecting any medicine, and we need to tell our staff, our nurses, that they have to remove all air bubbles from the system, and intravenous lines have to be very, very meticulously maintained. Another thing that we need to know is how much adherence is there to the treatment. And I think there was a lot of talk about it, whether to start with one drug or two drugs together, and the cost is another factor that comes. And KK was mentioning yesterday that in the Kerala registry, they realized that whatever is being prescribed is not necessarily taken by the patient. And I think every time we meet with the patient, it's our duty to find out how much is the adherence, whether they're taking the right dose, whether they're taking it something which is prescribed twice a day, once a day. And I think very often we will find that there are problems with that. Hyperthyroidism, fortunately, we probably wouldn't see it because we don't have epoprostenol, but those who are on chronic epoprostenol therapy can get thyrotoxicosis, which can again add on to their problems. So to conclude, I think medications are very, very important, but a part in the treatment of pulmonary hypertension. A significant number of serious events in these patients are actually related to ill-advised activity and unwarranted procedures. Pregnancy is one of them. Non-pharmacological measures are often underutilized in the care of these patients. Strategies that promote patient and parents' engagement are going to achieve the best possible care for these patients. And patient support groups are a valuable resource for educational and emotional support of these families. I think we are starting to see specialized pulmonary hypertension clinics in India. I don't know how many of us have dedicated pediatric pulmonary hypertension clinic, but I'm sure that is something that we're going to see in future. And I was happy to see Kokila Ben's website showing this clinic of a child with pulmonary artery hypertension. Thank you for your attention.
Thank you, Anita. Anita, one quick question, that how does this physical activity or exercise help this patient? Is it just like a feel-good factor, or?
I think the exercise capacity, even the oxygen uptake has been shown to improve. So it is a conditioning of these patients, because I think majority of us tend to tell them not to do this, not to do that. And doing an exercise which is not supervised is also could be harmful for them. So I think it actually helps them. And there's a lot of data on heart failure, exercise in heart failure. I think a lot of data has been taken from there, where actually their peak exercise, their 6-minute walk distance. So there is objective data to show that they improve.
Psychological thing really improves in PH clinics once they talk among themselves. One question which I'm not sure, one of the most important, when they come for surgeries, one question which the surgeon asks, laparoscopic surgery or open surgery? Is there evidence to support that abdominal distension volume decreases? Is there a scientific data to support it?
I haven't come across that particular question, but I think overall volume depletion, whichever surgery produces more rapid blood loss, is a longer surgery and has volume depletion, is going to be worse. So from that perspective, I think laparoscopic may be better. Only thing is that if somebody gets into a trouble with laparoscopic surgery, then one needs to go for open heart procedure.
But the anesthesia comes back, they're going to have abdominal distension that is going to compromise the lung volume. So should we go for open? This is a cholecystectomy. We have almost 4 patients, Eisenmenger, who are undergoing cholecystectomy.
Okay.
And this was a typical question which was asked in each of them: should I open it or should I do abdominal distension?
I don't know, maybe.
And general anesthesia and epidural, you nicely answered, obviously.
But
most
many
of
times
them
you end up with general anesthesia despite all this, because many surgeries cannot be done. Yes, yes. So, but if there is a possibility, one should try and go for epidural.
I think the issue about laparoscopic surgery, as you rightly point out, that it can decrease venous return, but I think it's more of a theoretical consideration. If you are closely following it, and the marginal changes won't affect, because the morbidity following a laparotomy is more than morbidity following a lap chole. So probably with just keeping that in mind and monitoring the volumes, you can go ahead with laparoscopy. It
may be quicker also compared to the laparotomy.